Hello, everyone. My name is Josey Oquendo. I'm a fourth-year medical student at Stanford applying to orthopedic surgery. I'll be discussing my work with Dr. John Voorhees on the evaluation of deformity in adolescent idiopathic scoliosis. There are limited tools available for screening and tracking of deformity in adolescent idiopathic scoliosis, also referred to as AIS. Scoliometers are widely available, but they're subject to human error and provide an incomplete representation of deformity. Radiographs are considered the gold standard for diagnosis and monitoring of scoliosis, but X-rays are pretty costly and expose patients to radiation. Mobile device-based white light 3D scanning has the potential to be used as a tool for screening and monitoring of deformity. And in this study, we sought to describe how measurements obtained through white light 3D scanning can relate to radiographic and scoliometer measurements typically used in practice. All patients were recruited from LPCH-affiliated orthopedic clinics in the Bay Area. We included patients being diagnosed with or evaluated for AIS who were between the ages of 10 and 18 years old. In order to be included, patients needed to have an AP scoliosis radiograph taken within 30 days of clinic presentation, and they could not have had any history of spinal surgery. We also excluded patients who had non-idiopathic scoliosis, such as those with syndromic or neuromuscular scoliosis, and we excluded patients who were unable to ascend. In addition to 3D scan capture, each patient also completed a Scoliosis Research Society 30 questionnaire during their visit. 3D scans were taken in the upright and forward bend positions as shown on the right. For the bending position, patients were asked to curl their backs as much as possible in order to maximize visualization of spinal curvature. Image processing and computer modeling software was used to make 3D measurements of trunk shift, coronal balance, and clavicle angle in upright position, and largest angle of trunk rotation in the lumbar and thoracic spine in the bending position. 3D trunk shift, coronal balance, and clavicle angle were compared to their analogous radiographic measurements, and 3D ATR and scoliometer-derived ATR were correlated to major curve magnitude. So for those unfamiliar, the trunk shift describes the medial lateral shift of the thorax compared to the center of the pelvis. To measure this radiographically, you first draw a horizontal line across the rib cage in the area of greatest deformity. A vertical line through the midpoint of this horizontal line compared to a line that passes through the center of the sacrum. This kind of distance that you see here is what describes our trunk shift. Similarly, for coronal balance, we're looking at the medial lateral shift of the neck as compared to the center of the pelvis. To measure this radiographically, you take the center of the C7 spinous process, draw a line straight down through it, and the distance from the central sacral vertical line as shown before, and the line that was created through C7 is how we calculate our coronal balance. The clavicle angle is measured by finding the angle between this horizontal line that you see here and the line that passes directly through the anterior acromions. So this is the angle right here. And finally, the angle of trunk rotation was approximated using a scoliometer measurement. Patients were asked to bend forward so that the portion of their spine with the largest deformity was directly parallel with the ground. And the scoliometer acts as a level of sorts, and a measurement can be directly obtained from the tool, as you can see here. Backwards, there we go. To calculate coronal balance and trunk shift in 3 dimensions, 3 axial cuts were established. First, we made a cut through the level of C7, so right around the center of the neck. A plane was then drawn through the trunk at the level of maximal asymmetry. And finally, a plane was drawn through the hips at the approximate level of the iliac crest. All of these planes, we then took the centroid of the axial cut that went through the planes, and we projected them up to the neck, as you can see here, to make our calculations of trunk shift and coronal balance. So as mentioned, the trunk shift is calculated as a medial lateral distance between the trunk centroid and the hip centroid. You can see that over here on the right. And similarly, the coronal balance was the medial lateral distance between the neck and the hip plane as seen here. Clavicle angle was pretty intuitive. We just found the bony landmarks of the anterior acromion and compared it to a horizontal line that was parallel to the ground. And that was our clavicle angle here. And then for angle of trunk rotation, we looked at a line parallel to the ground and the line that was created by the deformity of the back. And we found this angle in the thorax and in the lumbar spine to calculate our 3D ATR. Our data set included 105 unique patients and 118 visits, so some patients did come back for follow-up. The mean major curve magnitude was 28.4 degrees, and the median age was 13.9 and ranged the entire span of our included range of 10 to 18 years. In the figures shown, comparisons were made between radiographic and 3D measurements of trunk shift on the left, coronal balance in the middle, and clavicle angle on the right. You can see the correlations were pretty high between the 3D and radiographic measurements. They were 0.9, 0.85, and 0.73 respectively. We then correlated 3D angle of trunk rotation and scoliometer measurement to the major curve magnitude, which is a major metric that's used for diagnosis of scoliosis and to kind of guide treatment as of right now. And we found that the 3D angle of trunk rotation had a higher correlation with the major curve magnitude than the scoliometer measurement. Finally, we correlated 3D angle of trunk rotation, scoliometer measurement, and major curve magnitude with the total SRS-30 score, which is a patient-reported outcome metric pretty commonly used in spine research. We found that there was a weak negative correlation between the 3D and scoliometer measurement and the major curve magnitude. There wasn't a big difference here. And then we found the major curve magnitude had a slightly larger negative correlation with major curve magnitude or with a total SRS score. In summary, we demonstrated that mobile device-based 3D scanning can accurately identify clinically relevant scoliotic deformity. This new modality may facilitate scoliosis screening and monitoring, perhaps decreasing the need for in-person clinic visits or radiation exposure associated with traditional screening methods. In our future direction, we're actually continuing to enroll for this study and will be for the foreseeable future. As patients return for follow-up, we'll begin to make comparisons between baseline and follow-up scans between patients. And ultimately, actually, our goal is to create an app that can automatically create all of these measurements so that we can put this in the hands of primary care physicians and specialists around the country. I'd like to thank Dr. Voorhees and Dr. Gardner for their leadership on this project, and would also like to thank the many medical students and research coordinators who have been assisting with this project and who continue to assist with this project. And finally, our research team would like to thank the staff at the Stanford Pediatric Orthopedic Clinics for their help and support on this project. I can now take any questions. Thank you so much.
Thank you, Josey, for that wonderful presentation. So let me see if I don't see questions here, but I had a question. So this is a mobile-based sort of an application. That's how we envision this, right? So how much training is involved, like in terms of like, is there a possibility for user error in terms of capturing that information? And have you looked at that? And
that's an excellent question. That's definitely something we consider. We definitely we're considering, how much are we going to be able to train people? We eventually want this to be able to be used in the home. We want parents to be able to follow instructions and be able to do this on their own. And so as of now, it doesn't require quite a lot of training, but you do need enough space. And that's something that we run into as we do personnel turnover. Getting a sense for how much space you need and how quickly to move with the iPad around the patient can definitely be a bit of a learning curve. But people tend to get it after 2 or 3 times trying this out and kind of getting a sense for it. They tend to pick it up pretty quickly. I think the question will be as we move past, those of us in the clinic who are all, millennials and know how to use the iPads and putting this in the hands of other people. I think that's when we're going to have more of a challenge.